Hi guys, my name is Milan and I will be presenting the Change Quality Management Project on Catheter-Associated Urinary Tract Infections, also known as CAUTI, in relations to the Plan, Do, Study, Act model of quality improvement. PDSA cycle, issues identification. So the problem is the catheter-associated urinary tract infections, also known as CAUTI, in the hospital setting. According to the Center for Disease Control and Prevention, or CDC, among urinary tract infections, or UTIs, acquired in the hospital, approximately 75% are associated with a urinary catheter, which is a tube inserted into the bladder through the urethra to drain urine. 75% is a very large number. It's greater than half. So this is also the second most common cause of bloodstream infections, which substantially increases institutional death rates. Over 13,000 deaths are associated with UTIs each year, and this can be preventable. So 15 to 20% of hospitalized patients actually receive urinary catheters during their hospital stay. The risk increases 5% per day of indwelling time. CAUTIs add up to $500 to $1,000 to the direct cost of acute care hospitalizations. A total of over $340 million spent in healthcare is to the incidence of CAUTIs in the United States each year. Like I said, this can be prevented. We can be saving this money. So Medicare will not pay for preventable hospital-acquired complications, not only CAUTIs, but PICC line infections or hospital-acquired wounds. This is one of their high priorities of CAUTIs due to the high cost and high volume. So issues identification continued. The signs and symptoms of CAUTI: fever, chills, rigors, unexplained fatigue, purulent discharge around the catheter, leukocytosis, bacteria, pressure, pain, or discomfort in the lower back or abdomen, confusion, hypotension, sepsis, and even death. Some patients may be asymptomatic and not even see these signs and symptoms of CAUTI, which is really hard to diagnose. So quality variance, standard versus evidence. So the standard is to decrease the rate of CAUTIs by 50% within 1 year by achieving high levels of performance in the preventative measures. The United States Department of Health and Human Services declared new targets for the National Action Plan to prevent healthcare-associated infections, including having a goal of 25% decrease in the amount of CAUTIs by 2020. So hopefully we can reach that by 2020. Evidence. According to the National Action Plan to prevent healthcare-associated infections, their previous goal in 2013 was to decrease CAUTIs by 25%. Unfortunately, no progress was made by 2014 and continues to stay unchanged. So CAUTIs continue to stay at an all-time high as they are the second most common type of healthcare-associated infections. Again, this could be preventable. So on my unit in our hospital, our supervisors review all the patients with Foley catheters. They use a checklist to make sure that it's appropriate for them to have. You know, if it's not indicated properly, the physician must be made aware immediately, so the supervisors will let the nurse know to let the doctor know. So according to my nurse leader, we actually have a decrease in the amount of CAUTIs over the past several years because we have very strict policies and procedures in place. That's good for us. So root cause analysis. Some of the reasons that CAUTIs can develop are because of the inappropriate sterile aseptic technique, over-insertion or inappropriate indication of a Foley catheter, inadequate and proper cleaning, pre-insertion infections, and leaving them in for too long or longer than indicated. So incontinence alone is not a reason to put in a Foley or indwelling catheter. So the scope of the problem. These are the following stakeholders within the instance of a CAUTI. Stakeholders are very important in these types of situations. So the hospital and facilities and insurances are directly affected as costs are going up and they're not getting, hospitals and facilities are not getting the adequate reimbursements because of CAUTIs. Employers like healthcare providers and nurses are directly also being affected because they have to do more with a patient who has developed a CAUTI, like give more antibiotics or maybe even pain medications, or cleaning more, cleaning the patient more, doing pericare. but more orders have to be written and followed through by the doctor and the nurses, possibly transferring them to a higher level of care or acuity depending on the circumstance. Infection control also is directly affected as they now have to go to bedside. They have to speak to the nurse. They have to speak to the doctor as to why this is happening. Why is their CAUTI happening? And what are the appropriate steps and measures to take to prevent them and to decrease them, as well as how to fix them. So solutions. Obviously, to prevent a CAUTI altogether is to not use any type of catheter, indwelling Foley, whatever, if possible. There are other ways to consider alternatives to indwelling urinary catheters, like pads or condom catheters or in and out catheters. Obviously, you have to be careful of skin breakdowns with using pads or anything like that, so you want to clean them right away. So according to the CDC, standards for eliminating CAUTIs include only using catheters when appropriately indicated. You want to remove as soon as possible. Ensure only properly trained people insert, maintain, and remove catheters. In our hospital, it's usually the RNs who insert, maintain, and remove catheters. In some instances, the doctors do it depending on the patient and circumstance. I know that outside of California, sometimes the CNAs will put in the Foleys, but that it does not go at our hospital. So use aseptic technique during insertion and maintain a closed drainage system. Always maintain obstructed urinary flow. So always check when you get on shift, throughout the shift, at the end of the shift, that the patient is having good urine output. Staff education about catheter management along with regular monitoring and cleaning will help reduce the risk of CAUTI instances. You also want to consider, like I said, other alternatives. There are alternatives to catheter use, and definitely use a bladder scan to determine whether a catheter is needed. So solution implementation. Educate the staff on the science of safety and on the appropriate indications for urinary catheter at least twice per year. Continuous education is key. If they see that CAUTIs are increasing, possibly educate the staff quarterly. Provide current policies and procedure handouts on catheter standards and guidelines. In our hospital, our supervisor actually made us a book on the current policies and procedures in regards to catheters, in regards to PICC lines, in regards to wound care, everything with the current policies that are in place. So this helps the nurses and other staff members refer to it while they're in the work field. So all nurses, regardless if they're new grads or not, regardless if they're 20 days old nurse or 20-year-old nurse, they will need to demonstrate proper insertion, maintenance, and removal technique to like a supervisor, committee, or mentor. Annual skills checkoff should be completed as part of the job routine. Develop a plan for ongoing education of staff, including physicians, about the appropriate indications for urinary catheter use and proper care and maintenance of catheters. Obviously, collection data, analyze, and making changes as necessary is key. Stakeholders do play a major role in reducing the risk of CAUTI, so make sure to educate the physicians, infection control, everybody, all stakeholders. So timeline. I created a timeline between month 1 and month 12, so within a year time period. So month 1, identify the problem that has not been met for CAUTI target if applicable. Create a CAUTI team with collaboration of nurses, supervisors, and infection control. This can range from 5 people to 15 people, however enough to create a team. So month 2 to 4 is to re-educate unit on CAUTI bundle with emphasis on alternatives to invasive urinary catheterization, appropriate indications, insertion, maintenance, early discontinuation, and urinary sample collections. Also includes supervised catheter insertions, cleaning, and removal skills. So also in this time period, 2 to 6 months, collection of data. 6 months should be half a year, so that should really determine, have these measures in place and these interventions actually decrease the risk of CAUTIs, or what are we doing wrong, what are we doing right? Month 6 to 12 is kind of the same thing. You're going to analyze data and edit accordingly. So a year really gives an overall picture. 1 month to 6 months is a great time to make major changes if necessary. So analysis. Data collection will include indication, gauge number, whether you use a 16 gauge or 18 gauge Foley catheter. Date, time, location, like the unit or floor that you're on of the insertion and removal. So in our hospital, we actually have these little tags that we put on the Foley catheters once we insert them. Also, reason for removal and date of removal, and name of the staff member who inserted and removed the catheter. This is very, very important because if the patient develops CAUTI, we can go back to the nurse and talk to the nurse. Did the nurse use proper technique? Were there other reasons? Kind of like, what's going on? Why did this happen? So proper maintenance and cleaning documentation is key. In our hospital, we must document every shift on did we clean the Foley, all of that stuff. Microbiology collection is very important, especially if the patient develops a fever or other CAUTI signs and symptoms. Culture should be sent down to the labs immediately. And it's very important to also remember, is the patient going to have a Foley for long-term, more than 30 days, or short-term, less than 30 days? So the goal is to at least decrease a 50% decrease in CAUTIs hospital-wide. So the next steps are extremely important as well. These measures are in place based on analysis of the effectiveness of the change. So it's super important to stay up to date with current policies, procedures, and studies. It's always changing policies and procedures, and supervisors in hospitals need to be aware, as well as nursing staff, what's going on. So continue staff education at least twice per year. Obviously, if CAUTIs are decreasing, twice per year is okay. If there's an increase, maybe quarterly. Follow up with annual competencies for all staff members. And if the goal was not met and the program unsuccessful, reevaluate everything, all the data, and edit accordingly. If CAUTI rates will continue to rise, this will cause millions of dollars. It will affect stakeholders. It will affect everyone. It'll greatly impact the hospital, and worst of all, it will impact the patient. So these are my references, and hope you guys enjoyed it. Thank you so much.